It's my real pleasure being in this meeting. I would like to congratulate the organizers of Indo UK Resmeet 2023 for giving me this opportunity to talk about the scientific journey which we had with Vision and Eye Research Institute, Anglia Ruskin University in UK. So the journey started way back in 2003 when we started the doctoral program in collaboration with Anglia Ruskin University. And the first, uh, the light was seen in 2012 when we had Dharani, one of our optometrists, defending her PhD thesis successfully at Anglia Ruskin. From 2013, the collaboration started between the diabetic retinopathy research team and Shahina Pradhan, looking at many aspects which I'll be dealing with in subsequent slides. In 2016, it was my honor to become a visiting professor at Very. And the same year, we had Vishwanathan, our optometrist, completing his PhD from Anglia Ruskin University. Between 2013 to 2019, we had series of publications mainly related to structural and functional changes in diabetic retinopathy, falls, and physical activity in diabetic retinopathy. In 2019, it was again an honor to that Anglia Ruskin University very conferred honorary doctorate of health sciences to me. And since then, the research journey continues. We've been working on multiple projects related to qualitative studies of in diabetic retinopathy and low vision and hearing. Let's deal one by one these studies. So basically, if you subdivide the work which we have done with Very, we can divide in three buckets: the qualitative studies on diabetic retinopathy, the structural and functional changes in DR, and research related to hearing and low vision. Coming to the qualitative studies, diabetic retinopathy, there are the treatment compliance, screening is the low uptake of screening are the important challenges. And these qualitative studies, we were trying to understand what are the barriers of screening, why the treatment compliance is poor, and something to related to the physical activity behavior among people with diabetes. We did series of studies, not only in India, but also in South Asians living in UK, Nepalese population, definitely in Tamil Nadu, and also in Thailand. The tools which we had used in these studies range from focus group discussions, in-depth interviews, and variety of questionnaires. At this juncture, I would like to thank the Samarth group in Chennai who did qualitative research workshop to train our staff in doing these qualitative research. The patients in Tamil Nadu were recruited from the screening when we screen for sight-threatening diabetic eye disease. What we found were there are certain universal barriers irrespective of the country, the lack of knowledge, awareness about diabetes control. There were difficulties in doctor-patient interactions. There were time constraints, both from the patient and the doctor point of view to explain these things. The lack of appropriate educational or awareness programs, and certain rural areas, we found the limited access to healthcare as one of the important barriers. What we found that definitely we need to offer greater assistance, diabetes education resources, especially to the illiterate group, especially the diet and physical exercise counseling, need to do work on enhancing the doctor-patient interaction. And definitely there is a need for patient support groups. Particularly the telescreening approaches may play an important role. Taking clues from these qualitative studies, we also embarked on a scoping review looking at various looking at geographic atrophy. That becomes important because now we have a FDA-approved drug for it. We wanted to understand the impact on everyday life activities and the adaptive and coping strategies these patients have, those who have bilateral central vision loss due to geographic atrophy. This was part of a thesis topic from Mahe. These are the series of publications related to qualitative studies which came out from the project. We did some clinical studies related to structural and functional changes in diabetic retinopathy. These are some of them. Let's deal one by one. So we were keen to understand the early functional changes in diabetic retinopathy. Thanks to Dr. John Robson, who is a co-creator of the contrast charts. The problem is we know that contrast charts work pretty well. It can detect early stages of diabetic retinopathy. However, they are bulky, they need a definitive lighting condition, and it is more of a research tool. So Dr. Robson developed certain charts called as COM-blob charts. These are tear-off charts like the home Amsler. And we thought, can we use that for screening retinopathy? And we did some initial studies with patients with diabetes with and without diabetic retinopathy. What we found that these COM-blob charts were pretty good enough to differentiate people with diabetes and no diabetes. These are the AUC curves, and you can see a AUC value of 0.95 to detect diabetes and no diabetes. It could detect with reasonable accuracy whether presence of DR, any form of DR is there or not. It will also detect diabetic macular edema, one of the leading cause of visual impairment in people with diabetes. And if we combine the severe NPDR, PDR, and DME, the sight-threatening diabetic retinopathy, these charts could detect with a AUC of 0.84 presence or absence of sight-threatening diabetic retinopathy. We also looked into certain other changes, functional changes, and what we were keen was to look at pupillary dynamics. We know that autonomic neuropathy is an integral complication with people with diabetes, which affects the pupillary dynamics. To study this, we had a camera called as made by NIDEC, the Orion camera, which came with a pupil graph. And we tried looking at multiple parameters, the amplitude of pupillary constriction, velocity of constriction, the velocity of pupillary redilatation. And all these measures were seen in variety of stages of diabetic retinopathy, and some of them were significantly different between the various grades of diabetic retinopathy. We published that paper in scientific reports, and later offshoot of that project was we wanted to see, can we predict, use the predictive power of deep learning to detect the presence of diabetic retinopathy based on pupillary dynamics. And these are the results. You can see a pretty good AUC just using those parameters from a video. We can detect presence or absence of DR. We did some clinical studies to understand cataract and diabetic neuropathy. We had these questions. We were keen to know, is the cataract different in rural and urban India? Or is there any retinal functional changes which are present in diabetic neuropathy? For doing these two studies, we used our population-based data set, two data sets. One was people more than 60 years, the Nethralaya rural-urban age-related macular degeneration study. And for the diabetes, we used the SN-DREAMS, Nethralaya diabetic retinopathy epidemiology and molecular genetics study data set to come to the answers. We did find that the prevalence of cataract was nearly equal, nearly 40, 44, and 43% in rural and urban India, more than 60 years. We found that the prevalence of monotype cataract is higher as compared to the mixed type of cataract in both rural and urban populations. To our surprise, still the hypermature cataract is an important problem. Nearly 8.6% in rural India have hypermature cataract, giving us a clue that there is a need to strengthen our cataract services in rural India. And we also found that besides age, lower socioeconomic status was a risk factor in urban population. Coming to neuropathy, using the SN Dreams diabetic data set, we found that structurally there is no discernible changes which happen in neuropathy in the retina. However, there are functional alterations which happen in neuropathy in terms of retinal sensitivity changes. Again, offshoot of this project was to see if we can use the power of deep learning to detect neuropathy from retinal images. And this was a work which we did in collaboration with Cambridge consultants. In 2021, this was a blog which Cambridge consultant came out with. And when we did this study and we trained the model using patients with no diabetic retinopathy, this is the five-fold cross-validation result. You can see pretty good AUC to detect neuropathy, and the presence of diabetic retinopathy, we could detect these abnormalities, the neuropathy, much better. So for the first time, we demonstrated that retinal images in people with diabetes can be used to detect neuropathy. That becomes very important, especially in India, when we know that the prevalence of foot ulcer is very high. Nearly a quarter of diabetes have that. And we have nearly 100,000 people requiring lower limb amputation annually. Probably this gives a window that we can do both neuropathy and retinopathy screening together by taking a retinal image. We did some clinical work to assess the risk of falls in people with diabetes, especially microvascular complications. We used the fall assessment questionnaires, variety of questionnaires to assess the risk of fall. We also looked into the fall diaries and captured motion with 2D camera and then analyzed these to understand their walking behavior. When we looked into this group of those having only neuropathy, only retinopathy, and those having both retinopathy and neuropathy, definitely certain parameters like the lead toe crossing speed or the trail foot placement after crossing was different between the three groups. And what we found that the risk of falls is definitely higher in people who have both neuropathy and retinopathy. Second was people who have neuropathy, and lastly, probably having least among this group was retinopathy. Their walking became more cautious walking. They had less falls, less risk of falls. So the key findings in this couple of studies were we know that India has nearly 105 million people with diabetes. The current method of screening is a retinal camera-based photography. It's not practical to screen all these 105 million with a retinal photograph. Definitely, there is a need of a pre-screening tool, a tool which can find out the people at risk, and probably only those the retinal photography can be done. Contrast sensitivity and pupillary dynamics seems to be an effective pre-screening tool, however, needs more validation. We also showed that the risk of fall among people with diabetes is related to diabetic neuropathy and diabetic retinopathy. These are some of the publications which came out with these clinical studies. We also worked on hearing and low vision related research. So we know that once the sight is less, the other sense probably improves, and one of them is hearing. And that was the whole rationale of looking at these studies. We wanted to know that do blind people and partially sighted people have better hearing abilities? We also wanted to understand that how do the people with vision loss estimate the distance of sound source? In two different tasks, discrimination of the sound sources, how far is one sound away from the another sound, and estimating the absolute difference, how far is the sound source without any reference to an external reference source. We used the tools which we used to find out or get answers to these studies were the modified version of speech, spatial, and quality of hearing questionnaires, audiometry. We also did some virtual simulation using MATLAB. So we created a program so that it appears that the person is in a room, and in this room, The sounds are coming from variety of distances, the sound source one, and you have another sound source, the sounds are coming. We wanted to know the difference or distance between these two sound sources and the absolute distance of the sound from the person who is listening, maybe blind or partially sighted or a normal individual. So from the qualitative, the first study using questionnaire and audiometry, we did find that there is perceptual enhancement. There are certain auditory abilities which tend to improve and they help to compensate for loss of vision. Definitely, the visually impaired participant gave better scores than the sighted participants in all these questionnaires. Coming to the discrimination of the distance of the two sound sources, to our surprise, we found that blinds were more accurate than controls, and partially sighted who had only visual impairment, they were equivalent to the age-matched controls. However, when we tried looking at the estimate of the distance of one sound source in an anechoic environment or even in the reverberant environment, we found a similar thing, that the blind people, they fared worse. They were not able to judge the absolute distance. However, people who had visual impairment, partially sighted individuals, higher the vision loss, they had more overestimation of the closer distances. So these are the summary of the key findings which we had on our research on hearing and vision loss. These are the publications which came out from this group of research which we did together with Very. So the journey continues. A journey of research collaboration between Very and Nethralaya continues, and very rightly Helen Keller had told that alone we can do so little, together we can do so much. So let's strive to build bridges, not walls, in our pursuit of knowledge and discovery. At this juncture, I would like to thank the two teams for giving me this opportunity to talk in this meeting. Thank you very much. The team from Very and my research team at Nethralaya.